Now it's my pleasure to introduce Dr. Neil Sengupta, who's an assistant professor of medicine and part of our GI section. Dr. Sengupta was recruited here from his training program in Boston at Beth Israel, and we were delighted to welcome him. He's come and is now the director of our quality program and working carefully in our procedure unit, but he's also become one of the residents' and students' favorite mentors, because they know when they work with Dr. Sengupta, they're going to get a project done and it's going to be published right away, because he's very productive in that regard, and we're very proud to have him join us as faculty and to be with us now. So Neil, tell us about what GIRF is supporting.
Thank you so much. It's my pleasure to be here. Like David said, my name is Neil Sengupta. I'm a clinical gastroenterologist, and my research and clinical interests all kind of revolve around improving the way we deliver care for patients who are scheduled for a colonoscopy for colon cancer screening. So that's something that's relevant to really everyone. So for all of you who don't know, colon cancer is one of the leading causes of cancer-related mortality in this country. Thankfully, it's preventable through high-quality screening initiatives. And so colon cancer screening is recommended for all individuals over the age of 50 in this country. One option for colon cancer screening is colonoscopy. But in order to actually benefit from colon cancer screening, one needs to have a high-quality screening examination. So there are really three variables that determine a high-quality colonoscopy for someone who's scheduled for their screening colonoscopy examination. First of all, they actually need to come for their procedure. We have actually staggeringly high no-show rates in our endoscopy unit, which leads to really missed opportunities to screen patients. Second, they need to have a good quality bowel preparation. In order for us to visualize cancer and polyps at the time of a colonoscopy, the bowel needs to be cleansed with a laxative. And there's a good amount of evidence that really shows that the better the quality of the clean-out, the better the chance that your doctor has to find polyps and reduce your risk of colon cancer. And third, the procedure needs to be performed by a high-quality proceduralist or high-quality endoscopist. And there's actually objective metrics that are used to really determine an individual provider's success in preventing colon cancer in the future, and that's called an adenoma detection rate, ADR. What that stands for is the percent of the time that a gastroenterologist finds a precancerous polyp at the time of colonoscopy. So these three variables really determine a high-quality colonoscopy. So we actually at the University of Chicago have room for improvement in all of these. So as I mentioned, our show rates historically have not been optimal, which as I mentioned leads to missed opportunity to screen patients, which then leads to the increased incidence of colon cancer. Second, our bowel prep quality can be improved. And third, we haven't had a systematic, robust way of actually tracking important quality metrics for our endoscopists. In addition, we've traditionally used older ways of navigating patients through a colonoscopy. We've relied on paper handouts and actually nurses making phone calls to describe how to take a bowel preparation, when to arrive for the procedure. We're currently actually actively investigating novel outreach methods to reach patients, to really guide patients about every step of their colonoscopy. And so what we're currently doing is we're using text messaging, where we enroll patients who are scheduled for a colonoscopy, and we text them every step of the process to tell them what bowel prep to use, when to arrive for their procedure, when to take the first half of their bowel preparation, when to take the second half of their bowel preparation. And there is a good amount of evidence at other centers that has shown that text messaging through this platform can actually improve the quality of bowel preparation and improve show rates. So we're currently actively doing that at the University of Chicago. As I mentioned, adenoma detection rate is the most important quality metric that we monitor for endoscopists. Traditionally, that's been a labor-intensive way to measure quality because it requires communication through different software. Through the support of GIRF, we now have the resources to actually track this for our providers and thereby really determine how well we're doing in terms of preventing colon cancer for patients. So with that, thank you very much for the support, and I'll hand it back over to David.